So, hello everyone, and welcome to another one of our still COVIDing chats. Today we have Dr. Robert Groysman with us to talk about his new actual series of books, but the Complete Long COVID Handbook, which is coming out in volumes. And you guys can see that I have a copy here that I have perused myself and was really impressed with the information that Dr. Groysman has managed to sort of distill and actually put in a understandable form for anybody to come in and read. And it's a really great reference. It's easy to find what we need. And so we thought we would just have him come along and talk to our community. Now, Dr. Groysman is a practicing physician in Irving, Texas, and he does treat long COVID, among other things. He's board certified in anesthesiology. And so if you need some consulting help for long COVID, you could contact him at his practice. That being said, this is a public forum. Please do not share your specific personal medical information in this forum, and Dr. Grossman will not be able to give you individual medical advice. He will answer general questions, questions about long COVID, questions about symptoms, all of those kind of things after we get done, chatting for a little while. As usual, we'll take the questions in the chat and we will let Dr. Groysman have an opportunity to answer them. You can type them in as we go, but we will stop and pause at the end for the Q&A. Also, as a side note, I just do want to let everybody know that for the people affected by Hurricane Helene, we are opening our groups to mutual aid requests. We don't always allow them, but if you're in one of the still COVIDing groups and you're in that area that was affected and or your loved one and you need to post a mutual aid request, we will be allowing those for the next couple of weeks. And this is also going to be recorded, posted on our YouTube channel so that anybody has an opportunity to view them at their convenience when they get power again. Anyway, all of that being said, welcome, Dr. Groysman. Thank you so much for being here today.
Thank you for having me on.
We really appreciate it. And maybe we could get started. You could tell us a little bit about yourself and how you got interested in long COVID as a condition.
Sure. I'm a first-generation immigrant from the Ukraine, now that it's separate in its own country. And like every other immigrant back then, we went through Brooklyn, New York, and made my way over to Texas at some point because of the weather. I had got a bit tired of the 3 feet of snow and the shoveling that I had to do. And I did all my training in New Jersey, but ended up moving over to Texas again because of the weather. And what I do is mostly interventional pain management. And yes, I am boarded in both pain management and anesthesiology. So you're asking me how I got involved in long COVID. It was mostly by accident. So back before long COVID was a thing, and before we even knew what long COVID was, I was performing a procedure called the stellate ganglion block or stellate ganglion procedure for patients with PTSD. It was very effective. I was seeing somewhere 80 to 85% success rates, a lot of veterans and assault victims. And as I was seeing this, I started noticing some patients coming in with some weird symptoms. And at first, it was just loss of taste and smell. And after the block, it would come back. And that got me thinking kind of what was happening, what was going on. And as time went on from 2020 into 2021, we started seeing more and more symptoms occurring. And then long COVID was born, long haulers, long COVID. And I started doing more of these procedures for long COVID, and it was helping. And from that, I expanded and started learning. I said, what is this? I want to know more. And started learning more and more about long COVID, what it was, what was happening, the amount of symptoms involved, and all the mechanisms. And over time, I started figuring out what works and what doesn't work. Now, everybody has to start somewhere, right? And I've developed my own protocols and systems. And the way I treat it right now is split up into four causes. And I split the symptoms into one of these four causes, sometimes more than one. And the four are dysautonomia, mitochondrial dysfunction, gut dysbiosis, and MCAS or histamine. And depending on which ones are more active, that is how we treat it. We actually go after the cause, not the symptoms. I don't really look at if a symptom is improved or not. What we want to do is work on each of those causes, and that's how you get out of long COVID and go into recovery.
That sounds suspiciously like the volume division in your long COVID handbook. So, why don't you tell us a little bit about that? How the handbook is organized? And I'm assuming it's because you noticed that as you came from this procedure that was effective to sort of treating the whole person, because we all know that long COVID has over 200 symptoms. And so you were able to sort of categorically group these symptoms into these conditions. So why don't you tell us a little bit about what you saw and then how you organized your handbook based on your actual clinical practice?
Sure. So you know that from 2020 to 2024, we've had a myriad of different studies come out. Everybody gets excited about this biomarker or serotonin or complement or something else, and everybody gets all excited. Well, this has got to be the cure now. Well, what I've done is I've read through all these studies and I've compiled based on what I've read and also based on my own experience and a little bit of trial and error. And this is where this original book came from. And what I've done is that the original book contains all the four causes. It talks about some of the other stuff too that goes on, but really I feel that long COVID is composed of these four, and depending on the combination or percentages of each of the causes determines what symptoms you have. And what I've done is I'm working on the other four books which address specifically the causes. Okay, and the first one is already out. It's called the dysautonomia part of the book, and the mitochondria dysfunction is coming out probably in the next 2 months, and so forth. But the whole point of getting the first book was to help focus and organize people. Social media is great, but there's a lot of suggestions, some of them good, some of them are not so good, and some of them could be dangerous. So what I wanted to do is split up what I found into manageable sections and talk about why you're taking a specific supplement. What is it working on? How is it helping? Who should not be taking it? For instance, when I first started, it was all dysautonomia. Everything was about dysautonomia, which is why it's number 2 in the series, because everything was about it. And the funny thing about dysautonomia is there's really not a lot of things you can do orally for it. And let me clarify, POTS is not dysautonomia. Dysautonomia is not POTS. POTS is part of dysautonomia. It's a small part, but there's a whole other section of dysautonomia that is separate from POTS. And if you don't know what POTS is postural orthostatic tachycardia syndrome. And essentially all it is when you stand up, your heart rate goes up and you don't get enough blood to your brain and you feel dizzy and you feel like you're going to pass out and your chest is about to explode. So that's basically the gist of POTS. But most dysautonomia clinics, most POTS clinics, really all they're doing is treating the POTS. And there's a set number of medications and supplements you could take for POTS, and it just treats the symptoms. It doesn't really treat the cause of the problem. I wanted to go beyond that. So
Fun.
go ahead.
No, and having seen your handbook, I think you do a really great job of, the interconnectedness between the systems in the body, right? Because a lot of times we see professionals or doctors who want to treat the nervous system in isolation. And what I immediately noticed about your book is it's not systems in isolation. It is, the interconnectedness between the way the autonomic nervous system might affect digestion or might affect even the immune system and the nervous system interactions, those kind of things. I do have a question for you. The
Sure.
immune system, the immune dysregulation that comes with long COVID obviously is a really big piece. Are you planning on doing that mostly in your MCAS histamine volume, or are you going to do some of that with the mitochondrial deficits dysregulating the immune system, or are you just sort of weaving that throughout the 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 volumes?
Right now, it's mostly focused into the first volume and a little bit into the autonomia volume. The way I look at immune system dysregulation is, as you said, it has multiple different causes. And essentially, if we look at dysautonomia, which is abnormality in your autonomic nervous system, your automatic nervous system, the stuff that you don't really have to think about, like digestion, right? And your heart rate, those things kind of happen on their own. And there's these two arms to it. One is the sympathetic or the fight flight, and the other is parasympathetic, which is what the vagus nerve belongs to. And when the sympathetic nervous system is overactive, it also makes the immune system overactive as well. So it tends to promote inflammation and overactivity. You tend to have issues with autoimmune conditions when you're stuck in fight flight, and with chronic inflammation. Those two things kind of go hand in hand with fight flight. And the parasympathetic and the vagus do the opposite. They calm down the immune system. They say everything is okay, relax. And what's interesting is there's actually been several studies looking at treating immune dysfunction and autoimmune conditions using vagus nerve stimulation. So there is something to this.
Absolutely. Well, and maybe that you can tell us, you mentioned your, and I'm going to say this incorrectly, but the stellate ganglion block. Did I say that right?
Yeah,
Yeah. And then I noticed that there was also something called eat therapy. All of the people who are with us today may not understand completely, how the vagus nerve toggles us back and forth between the sympathetic and the parasympathetic. They certainly, and I'm not even super familiar. That was what was really also refreshing to me, is because I do a lot of, reading and researching and looking into data on long COVID and it's sort of, constellation of symptoms and conditions. But your book was the first time that I'd heard about these two specific procedures that seem to be something that you use really commonly and sort of prevalently in your practice. So, do you want to walk us through what these procedures actually are and how they interface with the autonomic nervous system and how they can help improve people's symptoms?
sure. So let's start with the stellate ganglion block or stellate ganglion procedure. So this is a ganglia or a collection of nerves. It's kind of like a relay that sits on the front part of your neck. It's not in the spinal cord or in the spinal canal. It sits on top of it or to the side of it. And all of the autonomic nervous system signals from the fight flight, they go through there before going to the rest of the body. So they start out on the brain or brainstem and go through this ganglia and then get transmitted to the rest of the body. So when your system is stuck in fight flight, it can't get beyond that high limit because it's already beyond it. So we need to pull it back to its limits. And that's what this procedure does. It temporarily stops the communication between your body and your brain, essentially, for the sympathetic or the fight flight system on one side. Okay, so you have two. You have one on the left and one on the right. And all it is placing a local anesthetic, which blocks the transmission of neural signals to go one way or the other. And while it's stopped, it lets it kind of reset and go back to normal. So most people tend to be right dominant. It has nothing to do with side hand you are. Your body just picks one. you don't pick which arm you prefer, right? Your body kind of does. And the same thing happens with the stellate ganglion. It usually prefers one side over the other. And there's no rhyme or reason to it, but about 80% of people tend to be right dominant, and 10% tend to be left dominant, and 10% tend to be non-dominant, which means both sides are used equally. It's like ambidextrous. So the procedure is well tolerated. It's very quick to do. I mean, I've done over 4,000 of these, and I use ultrasound to guide the needle, because I like to see where the nerves and the blood vessels and several organs reside, like your lung and your thyroid. And I prefer not to stick a needle through them. So that's why I use ultrasound. And you can only do one at a time, because if you block both, what can happen is your vocal cords can close. So normally, if you block one side, you get a little hoarseness or feel like a frog in your throat. And sorry, my light went out. But you can't block both at the same time. Have I seen them elsewhere done both sides? Yes. Thank God it wasn't a real stellate ganglion block, or there would be a ride, an ambulance to the hospital. So you can't do them at the same time. You can do them the same day, you just can't do them at the same time. So EAT works a little differently. It stands for epipharyngeal abrasive therapy. Now, the epipharynx is not a real structure in your body. It was coined in Japan. It's a structure or area that corresponds to the nasopharynx and the oropharynx area. And what's special about this area is it's covered in mucus, and you can't really wash it out well, not even with a neti pot or any kind of rinses. And underneath that mucus, you have all sorts of gunk that's been around maybe years. And there could be viral remnants, there could be allergens, and it's all kind of neatly packed underneath a layer of mucus. And while your body can't touch it, it can touch your body. It's causing chronic inflammation, maybe even low level, but it's enough to cause, the name of it is called EAT, EAT, stands for epipharyngeal abrasive therapy.
And it's also on the back of the book, and it's also on Dr. Groysman's website, which we'll give you before we're done here, where he sort of gives another explanation. So what kind of symptomatic improvement do people see when they come to you, they are
Sure.
suffering from long COVID, you evaluate them, what would make them good candidates for this therapy, and then what kind of symptomatic improvement might they see?
Sure. Let me just tell you one more thing before we could get to that. The action of what actually does the work here, okay, is cleaning out that mucus and all the gunk underneath it, okay? The bleeding that occurs helps wash everything out, okay? And the bleeding also tells us how much inflammation there is. The more inflammation, the more times you have to usually repeat it, okay? Plus, you're also stimulating a vagus nerve in a very, very unique way. You can't do this any other way, okay? You can't do it on your neck, you can't do it on your ear. This is stimulating it in your throat, okay? It's very well tolerated procedure. We numb you up with a topical anesthetic. It's just a spray. And you feel some pressure, but it's not really very uncomfortable. I've done it on young kids, and I've done it on older folks as well. And we also apply zinc to the area. So part of the action is the rubbing, and part of the action is the zinc, okay? Who qualifies for this procedure? I have a questionnaire for this, okay? It's very simple. What I'm looking for is things that are not usually managed with a stellate ganglion procedure. So one of the big ones is head pressure, face pressure or head pressure, headaches, fullness in the ears, tinnitus, feeling like you're underwater, feeling like your face is trying to come off your head, postnasal drip, changes in your voice, changes or problems with swallowing. Now, those are the main things I look at. However, it handles dysautonomia too, just it acts in complement with the stellate ganglion. I often do them together. So we kind of hit the dysautonomia from two different angles to affect change. You can pretty much affect anything that the dysautonomia causes normally, such as pain in the shoulders and head, what's called coat hanger pain syndrome, uh, chest pain or palpitations or pressure in the chest. Those kind of things tend to respond well. And some of the upper neuropathies, I wouldn't go as far to go after the legs. However, this was a surprise to me, but I wasn't even expecting this. But the stellate ganglion procedure that I do actually fixed the leg neuropathies, the small fiber issues that we see in long COVID. Now, it doesn't happen every single time, but it happens often enough that this is not a coincidence. Tinnitus, like I said, tinnitus is a big one. And I believe that that is a symptom of the dysautonomia. It's basically neuritis in the auditory nerve or the small endings in the ear. And it wasn't there before COVID, before long COVID. It shouldn't be there now. It's not because you were blowing up dynamite or jackhammering, right? Or sitting in the front seat of the large speakers and big concerts, right? So it's not there because of hearing loss. So it is treatable. It is treatable.
So, what if someone comes to clinic and like dysautonomia doesn't really seem to be their presenting symptom? What if they are, say, I don't know, I'll just pick something, very chronic fatiguey, instead of dysautonomia? Would you still treat them with these procedures, or would there be something else you would do for them if that was their primary presenting symptom?
So when I see a brand new patient in my clinic, or if I see them through a teleconference or telemed consult, I start from the beginning. So first is to eliminate any comorbidities, basically any other conditions that could be causing these symptoms. I don't automatically assume it's long COVID, and it may very well be, but we have to eliminate other medical conditions first. And that happens with history, and that happens with some lab work and imaging. So that's the first thing I do. Second, we'll go through every single symptom that the person has, and maybe 200. And like I said, we'll sort them into one of the four categories, and some symptoms can fall into more than one category. And then I will look and see which cause is most prominent. Now, usually people do have a prominent cause, and they may have just one cause, and some people have all four. So I would go after the most prominent cause first, and then I would follow it with the second most prominent. So if I didn't think it was dysautonomia, and by the way, you know that fatigue and brain fog can be caused by dysautonomia too, but it could also be caused by mitochondrial dysfunction. It could also be caused by gut dysbiosis from the gut-brain axis. So, and it could be caused by MCAS. So that one you can spread all through four causes. So I would look at the whole person basically in their entirety and figure out which one is the culprit, and then we go after and destroy it.
What I'm hearing is it's a really personalized approach. It's not like a one size fits all. It's more like that you have sort of a structure around the way that you investigate everybody's individual personalized profile, and then you adjust your treatment based on the data, which, by the way, I just want to point out to everybody listening that that's what the best doctors do. They treat you, not the condition. So that's really great to hear. What about like viral reactivations? Can you say anything about viral reactivations and sort of where that fits in your framework? And
Sure,
and I'm not talking about COVID. I'm talking about like
I know.
post COVID, other kinds of like EBV viral reactivation or something like that.
Right. So the most common thing we see is a herpes family of viruses reactivation. And why herpes? Because herpes loves us very much. And once it comes into our bodies, it never wants to leave. Now it can become latent and it go into remission and go to sleep, however you want to call it. But it's always going to be there for as long as you're alive. And the top ones that we look at are Epstein-Barr virus (EBV), CMV, which is cytomegalovirus, chickenpox, which is the varicella virus or varicella zoster virus, and there's a couple other ones that sometimes we get as kids, but we don't really care too much about them, like roseola, hand, foot, mouth disease. They're caused by these lesser known viruses called HH6 or HH7 or HH8, HHV8. And normally you never hear from them again. You live out your entire life and they'll never bother you except in long COVID. Long COVID likes to reactivate these viruses, and it's almost like a biomarker. If you see the reactivated viruses, there's a good chance you have long COVID. So I don't think that the reactivation of the viruses is what long COVID is, but these viruses can certainly contribute to some of the symptoms, and you do need to treat these reactivations if they're causing a problem. Now, those are not the only ones. There's also Lyme and some other tick-borne conditions that sometimes kind of linger
Bacteria,
on.
yeah,
Yeah.
chronic infectious bacteria that could also be reactivated. But yeah, so again, weaving that throughout your volumes and your books, as you talk about your symptomatic well, they're not symptomatic categories, they're categories of etiology based on what the symptoms that you see, would be really helpful. So I just want everybody to know that you do take those kinds of things into account, as well. And then I also know from reading your book, you also understand the microbiome connection and the gut brain axis, and that can also be dysregulated in COVID. So, do your procedures actually help with things like, gastroparesis or other kinds of digestive issues, caused by long COVID? Have you seen any of that, or is that a completely different, treatment modality?
No, it's part of it. I believe in long COVID, it's mostly part of dysautonomia. And here's where the vagus nerve comes in. The vagus nerve controls about 75% of our gut. Now, our gut has kind of an internal brain system of its own, but you need a conductor for that, and that's what the vagus nerve does. You don't think about this, but the swallowing reflex, getting the food from your mouth into your throat and starting the process to be in your esophagus. It's not by magic. The vagus nerve actually guides the food through a process called peristalsis, and it's kind of like squeezing a snake from one end to the other, and opening up the sphincters to let it into the stomach and then closing it back up so that the acid doesn't spill over into your esophagus and cause acid reflux or heartburn, and then start the digestion process, right? The whole churning of the stomach, that's all vagus, and secreting the acid, that's all vagus, and getting the mucus into your stomach so that you don't eat a hole with the acid through your stomach, and all the enzymes that come from the pancreas and the liver or the gallbladder to help digest the food. So all that's handled by the vagus nerve. It's kind of the grand orchestrator. It's a very special nerve. It's one of the longest nerves in our bodies. In fact, vagus means wanderer in Latin. That's kind of how it got its name. And the process continues as it goes through the small intestine and large intestine, and then out the rear end. So all that's controlled by the vagus nerve. And gastroparesis, all it means is that things are slowed down. So now, instead of moving things along based on the pace that your body needs, things are just not really moving along at all, and food just sits there. And that can cause a lot of problems, including nausea, abdominal pain, bloating, and
Gut dysbiosis.
the gut dysbiosis, yes. And the thing about the vagus nerve is we know that the vagus nerve gets damaged or injured or inflamed. Okay, this has been shown in multiple studies, been shown on imaging. I see it. When I do my imaging for the stellate ganglion, I see the vagus nerve inflamed or enlarged. And when it's thickened, it doesn't function as well. So signals are not getting through as quickly or as easily. And I believe that's really the main cause of the gastroparesis that we see in long COVID. Now, not everybody has it, obviously, but our kind of model condition for gastroparesis is diabetes. And why is it diabetes? Because diabetes damages the autonomic nervous system. We know this. It's actually the poster child for small fiber neuropathy, right? Small fiber neuropathy, diabetic neuropathy, they're equal. That's diabetes, and it's used kind of as a model to show what gastroparesis does. So yes, it is treatable. You can treat it either through vagus nerve stimulation, or you can do one of these procedures to treat the dysautonomia. So there's a few things you can do. There's a few medications you can take to help move things along. There's some prokinetic medications that speed up the gastrointestinal process. And you treat the other symptoms like nausea and or vomiting and abdominal bloating. But that's essentially how you would approach gastroparesis.
So I know we've gone sort of into a lot of the science and sort of the etiology. Let's talk a little bit about what's in your book, because I just have to say I think it's incredibly generous. As one doctor, you can treat so many patients, but by compiling all of the information and putting it in a form where patients and other doctors can read about it, it makes it so much more accessible to a wider population. So really thank you for taking the time to do that for us. I know it's a huge amount of work. And I want to point out in here that there's a section even on labs that is compiled, and the lab work that even if you can't get to Texas and see Dr. Groysman, that you could ask your physician, your treating physician, to run, and then some of the implications of that. So do you want to talk a little bit about like the things that you do test just in that? You said in the beginning there's a questionnaire and then there's
Yes.
testing. What are some of the things that people with long COVID should be looking at or keeping an eye on with their physicians?
Sure. So let me first say, one of the reasons I wrote this book is because I've seen a lot of gaslighting out there, and people go to their doctors, somebody they trust, and they're basically being told, well, I can't find anything wrong with you. Your labs are normal, your MRI is normal, your X-ray is normal, everything is normal. Let me give you a referral to a psychiatrist. Um, part of the reason I wrote the book is to help doctors who have any interest in treating long COVID or helping patients with long COVID, to have a guide to use to what needs to happen. Okay. And yes, it is true that most of the labs are normal in long COVID. So the lab works, lab work that I put in there is not to diagnose long COVID, because you're not going to diagnose long COVID with blood work or with an X-ray or with an MRI. The purpose of the blood work is to look for any other problems going on. Is it affecting your heart? Is it affecting your lungs? Is it affecting your kidneys? Is it affecting your liver? Let's look at your clotting cascade. Make sure you're not forming clots unnecessarily. There's a lot of things that we look at that we can potentially get a glimmer of what else is going on, maybe alongside long COVID, because long COVID gets lonely and it likes to bring in other conditions like chronic fatigue syndrome. It likes to share. It likes to share. So we look at histamine to see if there's an involvement with excess histamine or MCAS. We look at clotting factors to see if there's an issue with clots. And like I said, we examine all the organs to see if there's an issue. I also look at general inflammatory markers like CRP, for instance, which is a C-reactive protein, to see if there's an inflammatory state happening. So we look at white count and some of the parameters to see if maybe there's an infection alongside. But none of these things are really telling you you have long COVID. You know you have long COVID. I mean, you're there because you have long COVID. You just need to be validated. And that's what this book does.
The book validates you, and it also organizes you, so you can go through one by one. Okay, here's my symptoms, here's where they fit, here's the testing that I could have done. And it even goes into some, it's nicely referenced. A lot of the studies, section by section, are here, that you can share with medical providers or read for yourself. And then there's also like things you could try, or things that, for each condition. Here's maybe some supplements that work for people. Here's some medications that work for people. Here's the other kinds of, things that might be helpful under this situation. I even saw that there were instructions for the ear stimulation of the vagus nerve with
Yes,
the TENS
so
machine.
I prefer to use the ear over the neck, and here's why. I mean, going to the neck is kind of taking a sledgehammer to it, and typically stimulation of the neck is 2 to 3 minutes or less. Certainly no more than 5 minutes. You don't need to spend $1,500 on a stimulator. It doesn't need to have weird things like the fit over your face or fit over your neck or make you feel like you're being choked. I feel that the ear is much gentler, and I'd rather go slow and longer than sledgehammer it for 5 minutes.
And we're
If you
talking
try,
about the TENS machines, not the
we're
stellate
talking about
ganglion
the
block is something
stimulation,
completely different. Yeah. So I just want people to know this is not the stellate ganglion block. This is
right?
vagal nerve
Yeah,
stimulation.
this is something you could do at home. You don't need to have it done at a doctor's office or any kind of clinic. You can purchase these units and do it at home. What I'm telling you is you don't need to spend $1,500, $2,000 on some type of vagus nerve stimulator that has all the bells and whistles. You can get it done with a device that's $50 or less. And we're blessed to have the vagus nerve innervate our ear, so we can access that area through the ear. I don't know why we're designed that way. It doesn't really need to be there, but I'm glad it is, because it makes it easy to stimulate. So I'd rather stimulate at the ear for 30 minutes a day, maybe up to 60 minutes, and not 5 minutes at the neck.
And I
Okay.
see here there's a whole section here in the first um, book on vagus nerve stimulation, where to place the ear clips, what are the TENS parameters.
Right.
So it's not just, hey, there's this thing out there that might be able to help you, go search for it. There's a thing out there that might be able to help you, and here's where you can find it. And so that's another thing that stood out to me, with the compilation of the information that's in the book, is that you didn't just stick to, sort of this theoretical knowledge. As a treating clinician who actually works with patients, then you have a unique perspective about what does and doesn't work, and a way to offer some just general suggestions or guidelines for each symptom in each kind of these categories that you've created.
Right. Everything in the book I have done or do. So there's really no theoretical parts in there. These are all based on experience and actual usage.
Yeah, and that's really great knowledge and information. So we have some really good questions coming in. If you're amenable, I can start,
Sure.
checking some of the questions, and then maybe you can help people out here. Again, keep these questions, please, to general medical questions, not, specific to your own personal confidential medical information. So the first one is, do you have a different way of handling things with people with known genetic mutations or enzymatic deficiencies like MTHFR?
Yes, I evaluate those as well, but I don't really test for MTHFR because it's not really relevant in long COVID, and here's why. If you look at the general population and I pick a person at random, 70% of people are going to have a heterozygous one gene mutation. So what that means is that in one of the two spots that are most common, they will have one gene that's a mutant. And we call that heterozygous. So that means that one gene will be wild or normal, and the other gene will be mutated. Okay, and only if you inherit both from your parents, you get both mutations in there, and then it becomes homozygous. So those are two different things. Neither of the two mutations is really all that relevant when it comes to long COVID, because long COVID does not interact with that gene or that enzyme. So that enzyme, the MTHFR, what it does is it methylates one of the B vitamins, right? Folate, which is B9, and that activates it. So all the vitamins that we take are in inactive form. So we need to add a methyl group, which is what methylation is. It doesn't interact with B12 or B2 or any of the other B vitamins, although some of them are needed for the process to occur. You do need some of the other B vitamins to act as cofactors. But my point is its only job is to methylate the folate, and we can actually bypass that by just taking a methylated folate, an activated folate. It's that easy. Or anything downstream. There's a bunch of things you can take downstream that will make that whole process irrelevant. So I know some docs like to do expensive genetic testing, and it's not really necessary because, like I said, 70% of us out there has at least one mutation out there. It has no clinical significance whatsoever. So most of the time it'll come back as heterozygous. Even the homozygous ones where you have both mutations, for the most part, is not going to be clinically relevant. The 677 one, that position, if you have a homozygous, your homocysteine level can slightly increase. Okay, homocysteine is the thing that I monitor for and test for because that's the end product. That's what I'm interested in. If homocysteine is high, guess what? You have a higher risk of getting clots. You have a higher risk of pregnancy. These are the things that it causes that we need to correct. I can do that without checking the MTHFR gene. I could just test
Yeah.
for homocysteine.
So what
It's
I'm
that
hearing is
easy.
you do work the methylation pathway, but just by
Yes.
indirect testing versus focusing on a specific enzyme
I just feel it
in the
doesn't really
pathway.
add anything to it. I mean, you can do it if you want to, but all I care about is the homocysteine high or not.
Well, if
If
you're
it's
giving people
high, I treat
methylated
it.
folate, yeah. All right.
I'm sorry, I didn't, I was talking and you were talking. I couldn't hear.
No, I did. No, I said, well, if you're giving people methylfolate, then you are jumping the enzyme. So that would, in effect, take
You
care of
can't
that.
fix the genetics, right? It doesn't alter what you do. Whether or not you have the mutation is irrelevant because you can't do anything about it, but you can treat the consequences. So why not
Right.
just check the homocysteine and be done with it?
All right. Next question. People with a history of trauma who have been living with fight or flight response, probably like improperly activated, does that make one invulnerable to viral infection resulting in lingering symptoms? Or is COVID the primary trigger to the fight or flight response?
Invulnerable. So somebody who is, for instance, suffering from PTSD.
Are they more vulnerable to, a viral infection making their vagus nerve go dysfunctional?
You are more vulnerable to getting long COVID. Anything that attacks your autonomic nervous system makes you vulnerable to long COVID. It doesn't mean that you're going to get it. It just increases your odds. That's all. So PTSD works kind of by a different mechanism. It works by the amygdala, which is a part of your temporal lobe. That's where you store traumatic memory. Um, and it's mainly there to protect you, right? So you don't go through that process again. So, but the trauma is so severe that the amygdala now fires off those fight or flight signals into the stellate ganglion nonstop. So it may be the origin may be different, but the consequences are the same. You'll have a severe case of dysautonomia. So yes, to answer your question, you'll be more vulnerable. Your odds would be greater. Any condition that damages or injures your autonomic nervous system puts you at risk, higher risk of getting long COVID.
Yeah, and we see that in the very, very early on. There were some mental health conditions that predisposed you or put you more at risk for long COVID, and I'm pretty sure that PTSD was on that list. Have you seen any CSF leaks from the idiopathic hypertension post-COVID?
So I do know that CSF leaks are associated with dysautonomia and POTS. They sometimes can occur what's called iatrogenically. So it's hard to know for sure if they're linked to long COVID or not, because they can occur normally in our population. So I haven't seen any studies yet that look at that specifically in long COVID.
I've seen some evidence about COVID and collagen signaling and how COVID will disrupt collagen signaling. And then people who already have collagen defects are also predisposed to things like CSF leaks. And
Sure,
so,
and that makes sense.
disrupting their collagen production might be one explanation for that. But you don't treat CSF
I
leaks, is
do,
that
and I
you
can,
do?
yes.
Okay. All right. So if you see them, you know how to identify them and you can
I know
also
how to
treat them.
identify them. I know how to treat them, yes.
All right. What about, are these possibly long COVID symptoms? Short-term amnesia, or I don't know what TGA is.
TGA?
TGA. Yeah.
E? E or
T
T?
T like Toby. TGA.
Okay.
It says short-term amnesia or TGA.
Yeah, I don't like using shorthand because it could sometimes stand for multiple things. If you can
Hmm.
define what TGA is, it would be helpful. But in general, those would be part of what I consider brain fog. And brain fog includes things with memory, concentration, what we call executive functions. So those include things like being able to change gears, essentially, go from one task to another, or not giving into an impulse. That all takes executive functions to do. And the concentration and mental fatigue kind of go transient global and amnesia.
Okay.
I'm not sure what that is exactly, so I apologize. But in general, memory is affected by long COVID. I'm not sure how long or what's involved with the transient global amnesia, though.
All right. You started talking about how most clinics treat the symptoms of dysautonomia and not the causes. Could you revisit that? Curious
Sure.
about the causes.
So I have a lot of patients coming to my clinic, and they're usually coming from another long COVID clinic, a POTS clinic, a neurologist, or a dysautonomia clinic, and almost universally, everybody gets treated exactly the same way. How do they get treated? Well, first is the graded exercise or physical therapy, right? Then you have the components of the POTS. So they'll slow your heart rate down either with a beta blocker or something like Corlinor, and they'll increase your blood pressure with something like Midodrine, and increase fluids, increase salts, put some compression garments on, put in fludrocortisone, which is a steroid that causes you to retain salt. And that's pretty much 99% of the treatments universally. Any place you pick around the country, that's what they do. Okay, so even though they say they treat dysautonomia, even though they say they're a long COVID clinic, they're really treating POTS. And it's a symptomatic treatment of POTS. And that's great, except guess what happens when you stop the excess salt intake and the midodrine and the beta blocker, all the symptoms come rushing right back. So you haven't really fixed anything. All you did was put a bandage on it. You put a patch on it and called it a day. I don't like leaving it like that. I want to actually get rid of the POTS. And the POTS that's happening in long COVID is not the same kind of POTS that you get with other conditions. It is treatable in such a way that you don't have to continually take beta blockers, Corlinor, the midodrine, all these medications. So I don't know why that is, and doesn't really matter, like I said, whether they call themselves a dysautonomia clinic, if they call themselves a POTS clinic, if they call themselves a long COVID clinic. They all approach this the same way. They don't touch mitochondria, they don't touch gut dysbiosis, they don't touch the histamine issues. They focus on the POTS. That's it, 100%. So, and this, like I said, this comes from all over the state and also from all over the world. I don't know why that is, but it just is.
All right. So instead of just treating the symptoms of POTS, then you look at things like mitochondrial function and deficits that, the nervous system is the biggest energy user in our body. And that can help then treat the underlying cause of the dysautonomia or like you mentioned, the histamine issues. And then you're sort of doing an autonomic reset. And
Right.
so,
So let's talk about the mitochondrial stuff, okay? So we know that COVID, the virus, the SARS-CoV-2, directly attacks mitochondria. How does it do this? When it enters the cell, it tends to damage the mitochondrial DNA, and mitochondria are the only organelle or part of a cell that actually has its own genetic material, which is kind of interesting, and a double-walled cell membrane, which tells us it came from elsewhere. But what's interesting is when you damage a mitochondria, it's not just one. Mitochondrion is singular, but a cell may have 10 mitochondrion or may have 2,000, depending on what it needs to do. A cell like a nerve cell, it may have a lot more mitochondria because it needs to maintain what's called a gradient of most nerves are negative and they need to maintain this negative charge, and that takes work to do because you need to move ions around in order to do it. Plus, every time a nerve fires, you need to restore that old negative charge back to the nerve. So that requires a lot of energy. So when there's a significant amount of mitochondria in the cell that are damaged, they do not allow the fuel molecule to be processed all the way through. So ideally what happens is when you eat carbohydrates and fatty acids or fat or proteins, they get broken down in your body, and your cell sees the fatty acid molecule, they sees the protein molecule broken down into amino acid, and it sees the glucose molecule most often, and all those enter in. And what's supposed to happen is as it's processed through a cycle called the citric acid cycle or the Krebs cycle, is you're breaking down the molecule and releasing the energy out of it. And we have what's called electron transport chain because it comes down to electrons. And what is supposed to happen is each of those fuel molecules goes through their entire chain. There's 5 complexes, and each time it goes through a complex, something happens, and it moves protons from one end to the other, and that's used to power and create ATP, which is our main energy source. So, but what happens if it only makes it through the first complex and it gets kicked out early? It still has a lot of energy inside it, and that's what causes oxidative stress, and that can damage a lot of different parts of your cell and even organs. So what's supposed to happen is once it gets all the way through those 5 complexes, you're left with water and carbon dioxide, which is great because that's kind of the most reduced form of fuel molecule. We took all the energy out of it. But if you can't take all the energy out of it because the mitochondria are dysfunctional, it starts kicking out these intermediates, which are reactive and they're dangerous. So we need antioxidants that we have in our bodies that neutralize them. They basically scavenge them and reduce them so they can't cause any trouble. Now, in a chronic condition like long COVID, we tend to be a bit short on antioxidants because we're being exposed to these dangerous molecules all the time, 24/7. So that's kind of part of the mitochondrial protocol, is to start with the antioxidant phase and help your body out by neutralizing all these molecules that can damage your tissue. And the biggest concern is DNA, because these molecules react with anything they touch, and if they damage your DNA, that could be a problem.
And it also exacerbates dysautonomia, right? Because you have to maintain that gradient that you talked about. And if there's an energy stress on the system, then your nerves may or may not actually be transmitting properly due to
Well,
mitochondrial
sure.
deficit.
I mean, if you're looking at a nerve cell, there's going to be nerve dysfunction. If we're looking at the liver, you're not going to
Right.
be metabolizing properly. If you're looking at muscle, you're going to see muscle atrophy and weakness. So depending on which organ we're talking about, the response is going to be different. But yeah, if it happens in the brain, guess what? You got brain fog, right?
Mhm.
Because those neurons are not able to process information as quickly, or as well as somebody who doesn't have the mitochondrial problem. Now, what's interesting about the mitochondrial issue is everything we know about mitochondria comes from what we call primary mitochondrial disorders. Now, these come from children. So all your mitochondria are inside your mom's egg. That's pretty much our entire supply for our lifetime. And if your mom's egg tends to have damaged mitochondria in terms of genetics, there's not a whole lot you can do to fix that, because all your mitochondria in every single part of your body is going to have those damage, right? Because it's genetic. So long COVID is different. Long COVID only damages some mitochondria in some cells, in some organs. So depending on which organs it attacks, and gut is one of them, by the way, right? Because it loves the gut because of the ACE2 receptors. It loves the lungs. It loves the heart. When it damages those cells, it's only damaging a small portion of the organ. It's not damaging the entire organ, okay? So those damaged mitochondria in those cells kind of hang around. They don't go anywhere. They can't die. They can't replicate or reproduce. Basically, they can't split. And the main reason is because you need mitochondria to be functional to do those things. And the second part of what I do is get rid of those damaged cells.
All right. So mitochondria has a lot of implications. And when we're talking about root cause of certain issues, it can be a really big player.
Mitochondria has been implicated in most chronic disease, including Parkinson's, including Alzheimer's. It's pretty much prevalent in most conditions. If you look at the mitochondria, that's where it's coming from.
All right. Next question. How do you test for the three main viruses that are reactivated? And if they are reactivated, how do you treat them?
I test them by looking at antibodies to the virus. The only one that's a little tricky is the Epstein-Barr virus. There's two different ways to do it. One is to look at the early antigen, and that one it only increases when the virus is active. Some of the other ones, they just kind of linger around because you've had it. You've had mononucleosis, so they're always going to be positive. The second way to do it is to look at IgG over time and to see if the levels are increasing. That tells you that there's most likely an active infection. I treat them. I'm assuming you're talking about Epstein-Barr, and which other three viruses? Are we talking about chickenpox? Are we talking about cytomegalovirus? So I wasn't sure.
Yeah, I think she was just talking about the ones you referenced, but we can say, let's just pick EBV. How would you treat reactivated EBV?
So I first see if it was a problem,
Mhm.
because most Epstein-Barr reactivations cause absolutely no symptoms. So we need to first figure out if it's actually causing a problem, if it's causing a complication. Is it infecting your liver? Is it infecting your spine, your brain, your bone marrow? Those need to be treated quickly. And I treat them using an antiviral that's specific to Epstein-Barr virus. Okay, and the way these work is kind of interesting. Is they mimic, or they look like the genetic material that the virus uses to replicate, and it gets incorporated into the virus genome, and it cannot replicate anymore. There's a few other things that I do that would be considered off-label. um, so I don't know if I want to get into it too much, but I only treat it if it's a problem.
Okay.
So and you have to review it. So if you have Epstein-Barr and your liver enzymes are elevated, yeah, I'm going to treat. If I
Mhm.
notice that your white count is almost non-existent, or you have a severe anemia due to this, I'm going to treat. So it really kind of depends on what else is going on. But
Okay.
yes, I do treat these separately and distinctly from long COVID.
All right. Next question. Are all SGBs the same? If I can access one locally in my country at a pain clinic, would it be similar to your SGB for long COVID? Where can people get the stellate ganglion blockers? Are there other clinics that do that?
All pain doctors are trained to do a stellate ganglion block. They do it for painful conditions such as CRIPS or CRPS or stump pain. However, what I do is very, very different from pretty much any other pain doctor, and that came out of me doing thousands of these and coming up with my own technique. So asking, if one SGB is the same as another, no, they're absolutely not. Number one, some docs use fluoroscopy or CAT scan guidance. CAT scan is exposed to a huge amount of radiation, number one. Fluoroscopy is also not as safe because all you see is bone, and you don't see those nerves and blood vessels that kind of can get in the way. It is an advanced block. I have seen patients from other clinics have serious complications. But to answer your question, I mean, you can go to work in a Yugo or a Rolls Royce. They both will get you there. They both have four wheels and a steering wheel and doors, but they're very different, right? Even though both are called cars. So there's a very there's a huge difference between who performs your procedure. And like I said, what I do right now is very unique because it evolved over many, many, many blocks, and looking to see what worked better, what wasn't as effective. And my technique now is fairly unique. When it comes to pretty much anybody doing this procedure. Um,
So for someone who can't get to Texas, if they have an anesthesiologist that's willing to help them, is that something that you would like do like a peer-to-peer consult for people to counsel their anesthesiologist on if they were open to it?
I wouldn't necessarily talk to a doctor, but I can talk to the patient. As long as they use ultrasound and are fairly comfortable with anatomy, at least they can't do any harm. So I can't tell you if it's going to be a good block or not. 100% of my blocks are good. Um,
Okay.
and it wasn't like that in the beginning, but you know, most docs, they'll do 5 to 10 a month, maybe. I do 50 a week, just to give you a rough idea
Right.
on the percentages. And there's something that happens when you do them over and over again. You kind of get very, very comfortable with the anatomy, with the changes in anatomy. So
Mhm.
this area in particular tends to vary significantly from person to person, and you have to be able to recognize where you can and can't go. So yes, you can have it done locally if you feel comfortable with it. One of the things that I do is I inject in two different locations. I don't just inject where the stellate ganglion lives. I also go at the C3 or C4 level. That's the inferior, or I'm sorry, the superior cervical ganglia as well. So we're kind of catching two different ganglia, and that seems to have a better outcome.
How soon can patients see improvement after the block? Have you had a patient that has been cured of long COVID for a substantial amount of time?
So I don't use the word cure. I use remission or recovery, similar to cancer. This is a chronic illness. We don't know how chronic it is because we're only at year 4.5. So we have no idea what the future holds. I've seen it as, I've seen recovery, I'm going to say a remission, as early as before they even left my operating room table, my procedure room table, before I took the needle out. That's how quickly I've seen it. In some people, it can take a day or two. Some people, they come out, they don't feel any different, and it takes a day or two before their body is able to adjust. So there's a lot of things happening behind the scenes. It's not just blocking a nerve and walking away. There's certain processes that happen after the procedure, and the changes continue to happen even after you go home.
Do you accept insurance?
We accept insurance, but not for long COVID stuff.
Okay.
Just for pain stuff.
Okay.
And the main reason is because what I do is not really codable. So I can't code what I do as a standard stellate ganglion procedure, okay? Because that's not what the code means. Okay, code refers to putting a local anesthetic and a steroid into one area with fluoroscopy. I use ultrasound, I put it 2 areas, no steroid, and my technique is very different. That's number one. Number two, the EAT procedure, for instance, the epipharyngeal abrasive therapy, doesn't have a code. In fact, I am the only doctor in the United States that does it. I'm the only doctor outside of Japan that does it. So that means that there's nobody in any other country outside of Japan that does this procedure.
All right. What kind of COVID precautions are in place in your office? Are masks required? What other things have you done to your office to make sure that patients can come there safely without contracting COVID?
Sure, we go through different phases. Most of the time, we do wear masks. There are times when I guess COVID is down that everybody prefers not to. We will make everybody comfortable. Okay, if they want everybody masked, we'll get everybody masked. That's not a problem. I mean, we want to make it a safe and comfortable environment as possible.
All right. Will the dysautonomia book be useful for dysautonomia in general or only dysautonomia that is caused by COVID? That's a good question.
It's a great question, and it really will help any cause dysautonomia. It focuses on every aspect of dysautonomia, even outside of POTS, which is what's cool about this text. Is I gathered resources and information from other involvement of dysautonomia, and here's a cool little thing that you probably didn't even think of is vasovagal syncope, right? You heard that? Somebody starting an IV and they
Yep.
conk out on you, heart rate goes to 30, 25.
Yep.
That's dysautonomia too.
Yep.
So I address that as well, but there's a lot of different forms of dysautonomia, and this text really looks at all of them.
I think you have a
Except
copy with you. You want to show the copy of the second volume? Because the second volume is also out. So
the only thing I don't address here is the genetic or familial forms of dysautonomia, because there's not a ton you could do about it because it's genetic. I mean, you know, once you got the genes, you got it. You can treat the symptoms, but you can't really make it go away. But pretty much any other type, you can have an effect on, including ones from vitamin deficiencies, including ones from viral infections, including ones from autoimmune conditions like diabetes.
All right. There's a question. Are people with autism or ADHD more vulnerable to long COVID? And statistically, we know that's true. That's even on the CDC website. Do you have any ideas as why would that be true? Why would people with autism or ADHD be more vulnerable to long COVID?
Well, there's brain changes that are involved. So I would suspect that there's involvement of the autonomic nervous system.
That and there's also like immune deficiency is pretty common in autism, and um, there's also like yeah, like you said, brain changes, neurotransmission issues, and mitochondrial issues are also common in autism and ADHD. So sort of all your little categories, sort of those boxes get checked, right?
Right.
You mentioned testing for clotting factors. I thought I had understood that microclotting and clotting were different. Do clotting factors pick up microclotting? And which one's a problem in long COVID?
So they are very different. Microclots are seen under a microscope, and we have no idea if there's any clinical significance to them. Before COVID, people walked around with quote unquote microclots their entire lives. People do that in Alzheimer's. People do that in diabetics, diabetes mellitus. They have these microclots in their system, yet they're not placed on anticoagulants. So my question is there any clinical significance to them? Just because you found something doesn't mean it actually matters. Okay, clots do matter. Clots clots cut off blood flow. Clots cause heart attacks, they cause strokes, they can form in the legs called DVT or deep vein thrombosis, and then they can embolize to your lungs. Those are very serious. I mean, you can obviously form clots in any blood vessel. Arterial is more serious than venous. And when I'm talking about checking for clotting factors, I'm looking at fibrinogen and D-dimer mainly. Those two, because they tend to be elevated in long COVID in some people. And if they are, they may need to be treated, okay? And I may look for clots. I also look at homocysteine, as I mentioned, from the whole methylation thing. Homocysteine damages the endothelium of your blood vessel, which is the inside portion of your blood vessel. And anytime a portion of the inside is exposed, it can start off the clotting cascade, and you basically form a clot there. So it's important to know who's at risk for forming clots, more so than anything.
PT, PTTINR.
I'm sorry?
Do you test PT, PTTINR?
No, I don't. Oh yeah, because those are more useful for coagulopathies, more for bleeding. In other words, there's a deficiency of coagulation factors, and those tend not to be involved with long COVID as much as thromboses or embolic events.
Okay. Have you seen any correlation between long COVID and occipital lobe hemorrhages?
I have not. I haven't seen any occipital lobe hemorrhages come through on MRI or on diagnosis.
Have you heard of the use of peptides to help with long COVID treatment?
Yes, and I used to use peptides all the time before November 2023, when the government decided to make it very difficult to source peptides locally.
Okay. What do you think about red light therapy for mitochondria?
I think they'll enjoy the red light, but that's about it. Mitochondria don't get their energy from light. Chlorophylls do, and that's actually hold on, my light keeps going off.
Okay. Well, the red light therapy is for vascular dilation. So basically, by
Right.
oxygenating the tissue, then that's how it's supposed to upregulate mitochondrial function.
Right. I mean, look, red light or infrared light, near infrared light, NIR, those are useful for pain. They're useful for, like you said, dilating the blood vessels because it introduces more blood flow in, but I don't think there's any direct effect on mitochondria. Otherwise, would be plants. We don't have any chlorophyll or chloroplasts in our bodies. We don't get sustenance from sunlight. So why would you think red light would be any different than green light or yellow light or
Well,
white light?
my suspicion is that, like I said, the more availability of oxygen to the mitochondria, because that does upregulate mitochondrial function.
Sure,
But
but red light doesn't really penetrate very deeply. I mean,
that's true.
maybe a millimeter into your skin. If you really
Mhm,
wanted to dilate your blood vessels, sit in a sauna or get a heater or
mhm.
hot towel or sit in a bathtub or hot shower. Although don't do that if you have POTS. That's a bad
Right.
idea. Bad idea. But yeah, I mean, any heat is going to dilate your blood vessels. That's what heat does. So, I mean, I've seen people shoving red lights up every orifice in their body. Yes, yes, absolutely. Don't do it, please. Don't do it. Um, I mean, red light is pretty to look at, but it doesn't really have a whole lot of therapeutic value.
Okay.
I mean, there's
Do
other things
you
to do.
do virtual consultations for people outside of Texas?
Yes.
And do you want to share how would people contact you for one of those consultations? Would they do that through your website?
The easiest thing to do is to go on the website and go to contact us.
Um,
It's on a lot of the pages. I think it's probably on the first page too.
so you want to give me your website URL again? Give
It's
everybody your.
COVID. Sure, it's covidinstitute.org. Here, I'll even type it in here. And even though it says COVID Institute, I deal with long COVID, not COVID. The other one was taken.
So I'll just share my screen real quick and show everybody that okay, can you guys see my screen? Can you see the website? Okay.
Yeah.
So here's the website, covidinstitute.org. And then where did you say we go,
If
Dr.
you
Groysman?
scroll down just a smidge, it says contact us. That's where you would go.
So contact with us, schedule with us. Here's all of the information where you would go to request an appointment to be able to see Dr. Groysman at his practice or virtually if you're not in the state of Texas. And while I have my screen shared, I'm going to go ahead and show you guys that this presentation will be recorded here on our Still COVIDing YouTube channel. So you will be able to access all of the information that's given here today as well, and go back and re-listen and look at anything that you were interested in.
So this website I've been working on for more than 3 years. Um, everything everything that I learned about long COVID ends up here. And I'm talking about evidence-based, not
Mhm.
somebody he said, she said, or somebody on TikTok did it. I'm talking about stuff that we can validate and actually um, see what it does.
Yeah, and I can see here
So,
you have information about SGB and EAT therapy and vagal nerve stimulation, nicotine patches, MCAS. So there's a lot of information here on the website for anyone who wants to go check it out.
so this is the
Um,
pre-book, I would say. This is the pre-book. This is kind of what prompted this one. Over time, I was gathering all this information, taking notes, creating presentations, doing YouTube videos, and this is kind of a culmination of everything that's happened.
Yeah, so it's definitely probably a lot easier to carry the book around and make your notes and check maybe than try
So
to
I,
thumb through
I
the
I
website.
made
But
it this size on purpose. Okay,
mhm,
I didn't want it to be too small, like a 5 by 8, but I didn't want it to make it into an encyclopedia, which you'd have to put in your knapsack or something. I wanted something that would slip into a briefcase or a purse really easily. You can take it to your doctor, and like I said, if your doctor is at all interested in long COVID and not interested in sending you to psychiatrists, to the cardiologist, to the pulmonologist, to the neurologist, to the rheumatologist, to the immunologist, they actually want to help you themselves. This would be kind of the first step to learn about long COVID, to learn about my experiences, about what worked, what hasn't worked. And I mean, I have 4.5 years of knowledge and experience of this. Pretty much as you can have since that's how the condition is.
are there any good solutions for post-exertional malaise?
Yes. But again, it goes back to looking at the cause. And there's different things that can cause post-surgical malaise or PEM. And the top two are going to be dysautonomia and mitochondrial dysfunction. So we have to take it into context of everything else going on and then treat the cause. And that's how you get rid of PEM. And have I done it? Yes, I have. Have I done it more than once? Yes, I have. So it is
All right.
treatable. You can completely recover from it or pretty close. I mean, I can't promise you I'll get you back to 100% of where you were, but it's going to be pretty close.
In your office, do you have other mitigations like HEPA filters? Or I know some offices have FAR UV. Do you have other mitigations to prevent the spread of COVID in your office?
We have HEPA filters. We have medical grade HEPA filters.
Q30 collar is a device that was originally made for sports to help prevent concussions. It goes around the neck and puts slight pressure on
Yeah,
the
I have
jugular
heard of
and
it.
carotid.
I have heard of it.
Okay.
Yes.
Can you treat mitochondrial dysfunction via telehealth?
Sure. That one is treated with supplements and medications. So yes.
Um, if someone has viral persistence, would having a stellate ganglion block help the immune system reset and work to eliminate the remaining remnants of the virus?
So when we say viral persistence, what exactly are we talking about?
Yeah, I think this is talking about like a, well, I don't know. That's a good question. Maybe it's talking about reactivation, or maybe it's talking about persistence of COVID. I'm not really sure.
Sure, that's what I need clarified.
Yeah, that's because you're right. There might be a different answer. Okay. Do effects of SGB or EAT event gradually wear off?
Some people they can revert from the stellate ganglion procedure. So what I found is a very stressful event or getting sick again. Doesn't have to be COVID. It could be just the flu or a regular cold, and even sometimes having surgery can push you back into the dysautonomia state again because there's still some injury to the autonomic nervous system. It takes a long time to repair. So, but I
So,
have also seen people who are 3 years out and never needed to do anything else. As far as EAT, we don't know. Okay, the answer is we don't know. The application for long COVID is extremely new. Okay, even though the procedure has been around in Japan since the 1960s, it wasn't really used for dysautonomia or for long COVID. So the best answer I have is we don't know.
okay. Have you had to do it again for people, or would you, if it wears off, would you repeat the procedure, or you haven't really had repeat procedures?
So I've started doing them last year,
Okay.
and it's very new. I haven't had anybody come back for it, but in general, if you have a lot of inflammation there and you're scoring high on the questionnaire, you do need repeats. There's repeats until you get the inflammation under control. So somebody who's a grade 3 or grade 4 may need to get them several times, may need to get them 3 or 4 times or more. You can't stack them on the same day or even the next day. You need to give time for that area to heal, and that can take 5 to 7 days. So the answer to that also will be I don't know, because I'm really at the cutting edge here of long COVID care. So there's really nobody else that's doing this. So I don't have enough data yet.
Okay. Do you also see chronic pain patients that might not be COVID triggered? Yes, right?
Well, that's my pain clinic. Yeah.
Yeah, right. Okay. Would most of these strategies work for folks with MECS CFS from a pre-COVID cause?
Aha. Now you're onto something. So a lot of these things, a lot of these therapies come from MECFS, and a lot of these new therapies apply to MECFS. So for instance, some like EAT The epipharyngeal abrasive therapy has been shown to help with chronic fatigue. Some of the stuff I do for mitochondrial dysfunction helps with ME/CFS, because guess what? It's not just EBV that causes it. There's a considerable amount of people with mitochondrial dysfunction. So a lot of these are work in parallel. So actually, what I think probably the only good thing that's come out of long COVID or COVID is there's more research and more therapies available for chronic fatigue um, and ME/CFS, because that whole field has been stagnant for years. Nothing new has been coming out, no new therapies, no new medications. It's been the same old for what, 20 years. But now that we have a condition that's very similar, that acts and has the same course, a lot of the things that work for long COVID also work for the chronic fatigue. So yes, the answer to that is yes.
All right. And then to that previous question, they were talking about COVID persistence. Would resetting the vagus nerve, if there were any, COVID virus persistent in the body, would that help the immune system fight off COVID persistence?
Well, vagus nerve stimulation calms the immune system down. So if you have an active viral infection, you don't necessarily want to say stop to your immune system that's trying to fight off an infection. But in general, what vagus nerve stimulation will do is it will help with autoimmune conditions, because that's an overactive immune system. So to answer your question, it's not going to help clear the virus. It's not going to help. And you really don't want to use vagus nerve stimulation if you're fighting an infection.
So you want to take care of the acute infections or the
Yes.
reactivated infections first, and then do your procedures.
Yes.
All right. And then there's a question, how do we get the handbook? And so I'm going to go ahead and share again. The handbook is available on Amazon right here, both volume 1 and volume 2. So you can go it's just available directly from Amazon. Here's volume 2 down here, the pretty yellow one. I really like the cover of that one.
The mitochondrial one is red.
All right. Um, yeah, so that's how you get your hands on the handbooks if you are interested in checking out the wealth of information that is there. So I think with that, we will wrap here. But thank you everybody for coming and being with us. Thank you so much, Dr. Groysman, for sharing your knowledge with us and for
My
being
pleasure.
willing to treat this really difficult condition in our population.
My pleasure.